What's up, everybody? It's Michelle Renee from IamMichelleRenee.com, and today I have a very special guest with me, the beautiful, dynamic, also my soror, Dr. Lisa Flowers. How are you, Dr. Flowers?
Hi, how are you? I'm happy to be
Wonderful, wonderful. Thank you so much for coming on. It's critical in this time that we, one, see beautiful Black doctors like yourself who personify Black girl magic, but also that we take some time to really honor why we need to focus on the healthcare of Black women. So can you tell us first where you're from, who you are, and what your brand is?
Absolutely. I'm Dr. Lisa Flowers. I practice at Emory University Hospital and in Emory University School of Medicine in Atlanta, Georgia. I also, as part of practicing within the Emory healthcare system, I also practice at Grady Memorial Hospital, which is a safety net hospital. I am a gynecologist, but I actually specialize in women who are at risk for gynecologic cancers. That means women who are at risk for cervical cancer, vaginal cancer, vulvar cancer, women at risk for anal cancer, for ovarian cancer, uterine cancer, any one of those cancers. And I, of course, try to encourage colorectal screening cancer. That's my specialty. So anyone who has a genetic risk, such as women who have breast cancer genes that can put them at risk for breast cancer as well as ovarian cancer, or a woman, for instance, who has Lynch syndrome that can put her at risk for endometrial cancer, which is uterine cancer, or colorectal cancer. I'm sort of their doctor. I also, in the safety net hospital, I do also concentrate on women who have human papillomavirus infection or HPV or abnormal pap smears. What I really like is that even though I've been practicing in Georgia since 1999 and joined Emory in 1999, I come from New York City, and that's from the Bronx, the Boogie Down Bronx. That's where I'm originally from. And of course, I'm from, let's say I am African American and Latinx. And so I have that little bit of Caribbean flavor as well as, loving my Black heritage. And I feel like I'm very much committed to this population because, as you know, health disparities, especially in cancer, is a big problem in the African American community. And to be honest with you, we're the ones who suffer the most from it. So that's an issue. And
Absolutely.
that's always been important. One of the things about me that I think is also important is that I have a nonprofit organization called the Cervical Cancer Foundation, which used to be the Spirit Foundation. And I started that really because, what happens when you're in academic medicine, you could be in this ivory tower where you just expect patients to come and see you. And I felt like people weren't going into the community. They weren't going into the Black churches. They weren't explaining and building that trust within the Black community so that they feel comfortable in getting screening. So they feel comfortable in talking to their doctor about their concerns. And that they trust their doctor about whatever management they were recommending for their care. And so my nonprofit was focused on cervical cancer, but naturally whenever I've been asked to go to a Black church, which I've done for so many years and different types of churches, I kind of really stressed not only cancer, but of course, issues of HIV, issues of sexually transmitted infections, because there's so many questions the community has, and they don't have access to physicians coming on their grounds, meeting them where they're at to discuss these issues.
That's really powerful. So you just covered a lot about why you do the work that you do, but tell us a little bit about how you got into it. Like, what drove you as a young Black woman to say, I want to go into medicine, and why this particular medicine?
Wow. So what's really interesting is when I was in 6th grade, I love the sciences, always love the sciences. And, this is what tells you a lot about minority communities. The only prestigious jobs that I was exposed to were people of color use science as a way to really impact the community were physicians. I mean, that's really what it is. And I really try to encourage the youth now. God, they have so many options, so many options. And at that time, I saw the Black doctors. I had a Black doctor taking care of me as a pediatrician. And I said, I want to be that person. I want to be a physician. I want to heal my community. And literally in sixth grade, I made that decision pretty early and continued all the way through high school and college. You know what's interesting, and I want to really encourage a lot of people, ignorance is bliss, because I just said, if I study hard and I focus myself, I'm going to get into medical school. And what we don't really realize is the thousands and thousands of applications that actually go into medical school and the thousands of people that get rejected. But ignorance is bliss. And I try to tell all minority students, don't worry about the statistics. You do your work and you'll get in. And literally, I continued along that path and was fortunate to go to pretty dynamic colleges, like Oberlin College, which was very politically driven college. And then I went to Case Western Reserve Medical School, and it was a phenomenal education there in Cleveland, Ohio, and I enjoyed it. And I believe my first year, which was really dynamic, I thought I wanted to be a psychiatrist. And what happened was I realized psychiatrists don't talk to people. They just give drugs in the majority of cases.
That's it.
And I love talking to people. So that was not going to work. As you can see, I'm very chatty. So I got a chance my first year in medical school to take care of a pregnant woman and to see her through her entire, 40 weeks of pregnancy, to be there at her delivery. And then the next year, I went to all the pediatric visits with her.
Wow.
And that was such an amazing and impactful experience as a first year medical student that I just made that decision. I was going to do OBGYN.
Wow, like that, it's powerful just to watch the transition of, as a young woman seeing, or a young girl seeing, okay, you know what? I know I want to have an impact on my community. I know I want it to be in a really profound way. What way can I do that? Okay, I see doctors, and just seeing that progression. But look how God brought it full circle to say, no, you're not just going to have an impact on a community. You're going to have a dynamic impact on the way that you influence the way medical treatment happens for women all over the world. So I want to touch bases on that, because you don't just take care of women in the Atlanta area. You do a lot of work abroad. So let's talk a little bit about that. Tell the people what it is that you do worldwide with your organization.
Yeah, absolutely. I always phrase this because I'm hoping young people see this podcast so that they can understand, and even women, not even young people only, women of any age, you can turn around your life and you can make changes in your life that you can really, if you plan well and you get a mentor and you have somebody that sits down with you and says, okay, what's your 1 year plan, your 3 year plan, your 5 year plan, your 10 year plan? Literally, that's what I did with one of my mentors. And I envision educating physicians internationally and taking care of women internationally, and educating community health educators internationally on how they can screen and prevent cervical cancer, which was one of the cancers that has the highest rate of deaths in underserved countries such as Africa, India, certain areas of Asia, as well as Latin American countries. And so what I started to do was, with my national organization and with my nonprofit, I started to decide my efforts are going to be to go to Latin America, to go to Africa, and teach those physicians so they can appropriately screen women for cervical cancer. It is not, I love Doctors Without Borders. I love the people that go and they go and help the patients, and that's great. But you teach somebody how to fish, and they will continue to know how to fish, and they will be able to continue to take care of their patients.
You're creating fishermen.
That's exactly correct.
Yes.
And so I felt my impact was to go and teach 20, 30, 40 physicians, however many we can get in a room. Many times there's been 100, but then on the hands-on, there's about 30 physicians, and just teach them and train them and even if they have some basic skills, make them proficient in the ability to screen for cervical cancer. And I have been doing that, oh my gosh, for probably a good 12 years, or no, I think probably more. I mean, it's amazing. I love it. I've been to almost every country in Latin America. I've been to Ghana. I've been to Botswana. I've been to several countries in Africa. And I've been to China 5 times. I've been just everywhere, really working with physicians and training them, and and really taking care of the patients. And let me just tell you what's interesting. Here in the United States, we do consent when we talk to patients. We ask them what we're doing. We tell them everything of what's going to happen. There, it's not only going there and working with the physicians and making them proficient in the way to detect disease,
Right.
but it's that interaction with the patient, because those patients, they'll just get on the table, whatever the doctor says,
Yeah.
and you can see how they're slightly, how a little bit humiliated they might be and vulnerable. Women are vulnerable when they're getting screened in areas of their private parts, whether it's their breasts, whether it's their, you know, their vagina, their cervix, their pelvic exam. And I feel that my teaching, my interaction with these physicians and with these patients changed people in a way that not only was their approach to managing and training and teaching and caring for these patients improved, but their understanding of their interaction with the woman and making her feel like it is an honor to take care of you, which is because they were surprised. It's like, Dr. Flowers, we have to get to I said, wait a minute. I want to let you know it was an honor to take care of you.
Wow.
That what I saw today, you don't have cancer. You just have changes that we can change, we can treat, and you're going to be okay. And
that is so profound. Women need that. Like, not everybody needs that, because that's a basic human courtesy, right? That compassion. That's essential. Yeah.
And I tell you, like I said, I've been to, I didn't really understand how it's interesting, because I've been doing it for so many years, going to so many different countries, like I said, especially in Central America, and gone so many different times. I mean, every year I'm on 4 or 5 international trips to teach and train physicians and take care of patients. And I also bring a lot of equipment for these individuals through my nonprofit. And so that they'll be able to have sustainability, right? Because that's what we need. And I really didn't realize, you know, when I got a call and they said, well, Dr. Flowers, we want you to come out. And I said, you know, because I speak Spanish because my mother's Cuban. And I said, I'm happy to come. I said, but why don't I send some other people, or why don't, you know, trying to find a way, because I've been doing it so long. And it's like, well, don't you realize you're really well known here? And so people are going to come because you're coming. And I said, no. I mean, there's so many other people with big names. You need to get them over here. And they said, no, they know you and they know how you teach, and everyone likes your style and they want you. And I'm not saying this to say it as it just tells you how sometimes you go every day and you wake up in the morning, you take a shower, you plan to take care of your patients, you feel that this is what your calling was, and you have no idea how you're impacting people. And then suddenly somebody says that, and I'm like, and you're shocked. You're really shocked because you don't even realize what you're doing. And you're like, oh my God, well, thank you. I really don't see myself like that, but I'm happy to do what I can. And I just feel it's a blessing. Really, it's a blessing.
You created a vision, right?
Yes.
And you put a plan together and you execute it. So you're like, okay, mission accomplished. But then God doubled it back around and said, no, I need you to really sit in this moment and understand that what you're doing is so much bigger than just a plan that you believe to have executed, but you're really doing real work in people and communities to help them understand how to address the disparities, right?
Yes.
So that's extremely powerful. If you could give a few tips or a few important nuggets of what women need to do to be more proactive in their health, or what are some things that we could cover to make sure that we are not susceptible to these illnesses or these different diseases, and how we could be more proactive in our health. What would you tell us? What would you say? What are some tips as a physician that we need to know?
Yeah, I'll tell you this. You should not feel that the healthcare service is doing a favor for you.
Okay.
Meaning you have the right to ask your physician whatever question is on your mind and whatever concerns you have. You need to empower yourself when you go in for your annual examination.
Yes.
We're not doing a favor, you're coming in for service, and that service is to receive good health care, to learn how you should be able to take care of yourself, to get your concerns addressed, to know that you're doing the right things to make sure you have the longevity to live as many years as you should live if you are compliant with all of the screening guidelines that you need to take part in to make sure you don't develop cancer, hypertension, diabetes.
Yeah.
It is your right.
Yes.
And I feel so many times women come in and they feel like they're rushed in and out of a visit.
Like they're a burden. I've been there.
Exactly, like they're a burden. And that is not what we came into medicine for. And one of the biggest things I tell my patients, what I want you, or just tell women, I'll get calls from, a friend of mine's, hey, Dr. Lisa, I want you to speak to my friend. She's gone to a doctor, she's expressed her concerns, and the doctor seems to not be addressing it. And I said, well, that really shouldn't happen. So why don't you have her, get permission, send me her records. I review her records, gave her a little bit of pointers. And then what I tell her, why don't you tell the doctor that you're a really good friend of mine here at Emory University, and that your physician friend is a little bit concerned about some issues, and that they would like to be available when they're in the doctor's office with you, if need be, just to get some questions answered. And I actually help the patient make a list of all her concerns, because what happens with physicians, and I'm gonna give pros and cons. If you don't go in there organized with your questions, it's nerve-wracking. You go in there, you're anxious, you're already nervous about what's going on, or you will hope that everything is fine on your annual exam. And sometimes in that conversation with the physician, you had all these questions, but because they weren't written down, you forget. And then suddenly you're out the door and you can't get back in. The nurse has discharged you. You suddenly realize when you're putting your clothes back on, oh my God, I wanted the doctor to check this. Oh, I was concerned about this. And then you talk to the nurse and the doctor's gone. They're over with some other patient. And somehow you feel, I don't want to bother the doctor. I'll just address it on another day. No, this is your time. This is your opportunity. And you should take it for what it's worth. And so for instance, when I've done that, the doctor, it's a whole different interaction with the patient. They first of all, the patient gets her questions answered, and then if she feels comfortable, they either call me or don't, and they call me later and say, Dr. Flowers, thank you, because the physician answered all my questions, took more time than the physician has ever taken with me on a visit, and I feel like I understand everything that's happened. Or what happens is they call me and then I speak to the physician and I say, well, this is a family member or friend, and I just want to be able to make sure they understand in lay language what's really going on. So if you can convey to me what the situation is, I'm happy to talk to them, and then happy to do a three-way. And it really changes the whole interaction the physician has with the patient. Absolutely. Now, you say to me, should that even be the case? No, you're right. He or she should have that interaction, whether I'm there or whether that person knows a physician or not.
Right.
Because that's how it should happen. But it doesn't. And now I'm going to give you the doctor's side. We, unfortunately, in healthcare are given slots and time slots to see patients, either for annual exam, problem visits. And we are on this, unfortunately, everything is driven by how many patients we see and how much revenue and money we make.
Mm-hmm.
To be honest with you, it's not like the physicians are making a lot of money, the insurance companies are.
Right.
I'm going to be very honest with you. A lot of people think, oh, these doctors are getting rich. Let me just tell you, the insurance companies are getting rich, or the big healthcare system that they're part of.
Right.
But doctors do want to deliver good care, but you got to work with them. So how do you work with them? How do you make them commit to that Hippocratic oath, to do no harm and to provide excellent care to you? By helping them become good doctors. And the way to do that is by going to your visit prepared. Now, you're right. You may go in there and the doctor's like, you say, I have a list. And of course, some of them are going to go, they're going to take that breathe.
Yeah.
In reality, they're going to be really appreciative of it because you're organized and you ask your questions. Suddenly, what they might have thought was going to be a longer visit, it ends up being a very productive visit.
Right, because now you're targeting exactly what you need.
Exactly, and the questions are being answered, and you're not being brought back into the room because the patient forgot a question that now you got to spend another 10 or 15 minutes when you're out of the room, or you didn't do a part of the exam that was so important because the patient forgot to tell you she had a lump in her breast, or she felt this something that was odd in a different part of her body. Right. That would have been addressed. So primary, when you're planning to do your annual visit or problem visit, try your best to, write down whatever questions you have. Feel free to go on the internet. We know that patients are going to go on the internet. Are we going to be, I have to admit, when a patient says, well, I've been looking on the internet, I'll say, I bet you have. And then I'll laugh and I'll say, the internet can be scary, but tell me what you learned on the internet.
Right.
Just knock that out right away. Tell me what you learned on the internet in your own words. And then they'll tell me and I say, okay, now let me tell you what's right and what's wrong. And then we'll go through that. And then I'll say,
it's powerful though, to have someone that even is open to receiving. Okay, so I've been doing my own research because doctors are going in their head. Now, good and well, you are not a physician, so you do not know what you're talking about, but I'm gonna listen to you. So.
Exactly. And let me tell you, if you have a doctor that suddenly gets annoyed that you researched the internet or they're annoyed because you have a list of questions and that's not your doctor.
That's right.
That's not their doctor, because they really should be receptive to it because you're actually saving time and you're actually an educated patient and a patient who actually wants to improve their health. Right. So they shouldn't have any objection to that. Now, the next thing, how does the patient who has lower health literacy able to do the same thing? See, because my patients that are very well educated, that finally I kind of tell them, hey, do me a favor, just we're going to make another visit. Because I'll have patients that after their annual, like, oh, Dr. Flowers, I had questions, I can't remember. You know what? Let's make a 3-month appointment, a 2-month appointment, get your questions answered, get your questions put together. We'll meet again and you will address all those issues. That patient is almost, it's easier to work with, or if they have a certain problem, you can explain to them what are the screening guidelines, getting the tests that they should get, making sure they follow up, explaining them what the risks are if they don't follow up with their regular flu vaccine, with their pap smear as they should have it done, or HPV test, with their mammogram, if they're old enough, with their colonoscopy or the colon screening test. You can do that with a very proficient population that has a high health literacy level.
Right.
Okay. Now I will be honest. Even the most educated people, lawyers or whatever, health literacy, it doesn't mean that they have an A+ in health literacy. Right. Because, naturally we have our own language and you can't treat them like, oh, because they're a doctor, a lawyer, or what, even myself, I'm an OBGYN. And when I was pregnant, the assumption was that breastfeeding should come natural. I don't need any breastfeeding classes or the breastfeeding person to come after I deliver my child. I should know it. I had no clue. This was my first baby. What do you mean? I
Right.
was struggling. So it's unfortunate that even the healthcare system doesn't recognize that we are so subspecialized that we even need education. So what do you think the general population really needs? They need even more education.
Exactly.
So, I just wanted to make that out there because I don't want to make it seem like well-educated. We know we have health disparities in African Americans who are socially, economically stable, who still do not get the right care. And that's why they're still suffering from health disparities despite having access to healthcare.
Right.
That is a known fact. Think about the person who has poor health literacy, who has barely any access to medical care, or the medical care, they have Medicaid, Medicare, and they come in. How do they even navigate through the healthcare system and get their questions answered? It is the doctor's responsibility to speak in the language of the patient and to make sure the patient understands what's going on. Now, what the patient will do in that sense will say, whatever you say, doctor, I trust what you're recommending, but they don't know. So it is up to you as a physician. And I say, can you do me a favor, Ms. Brown? Tell me in your words what you think is going on.
Yeah.
And that's where you get an understanding of, does the patient understand? Do they even understand what's going on with them? And I'll find that the patient will say, they're there for cervical disease. And they're like, well, I may have bad cells in my uterus. No, in your cervix. Bad cells on your cervix. That's the part that dilates. It is part of the uterus, but it's really the bottom part. It's really the neck of the uterus. And it's what dilates when you have a baby. And that's different than what if you have bad cells in your uterus, because I'm sure you know some people who have uterine cancer. Yeah. And so you have to, and what happens is some doctors don't want to do it. You know why? It takes more time of the visit.
Yeah.
But then the patient leaves out, not knowing what they have, what kind of cancer they have, what kind of bad cells they have, and they communicate that bad information to their other physicians because they never understood what was going on.
That is so powerful. And you actually touched on the question I was going to ask, but you covered it. We're already at a disadvantage where there's a huge health disparity among Black women in the way that healthcare is received for us, to where the way our pain is received or perceived, better yet. And when we go to the doctor and we try to explain that something is going on with us, if we don't have the health literacy or we're not able to speak the language, then we're often taken as, one, not knowing what we're talking about, or not truly being in pain because we can't really communicate what it is that is ailing us. And how do we navigate a system that already doesn't believe us to be in pain or to believe us to be in this position of need? What do we do?
You've hit it right on the nose. Pain management in the African American population has been poor, has always been poor. When women come in for delivering babies, when women are coming in with chronic pelvic pain, there's a lot of assumptions that are made. One, that Black women are so strong and they can tolerate pain, that they have a high tolerance of pain, which is a myth. It is not appropriate. There's no evidence to that information. There's nothing genetically that proves that kind of information. And the other issue is, well, if they're complaining about pain, are they, drug abusing? You know what I mean? Are they trying drug seeking? And it's because, it is this assumption that they constantly have, either that, they can tolerate the pain, or they're drug seeking, or they're, it's in their mind. There's no recognition. And I always tell my residents, as well as my, when I speak to people that are medical students that are trying to learn, if someone is complaining of pain, you find the medical reason for that pain before you start assuming that it's psychological, that it's because of past trauma, that it's because it's drug seeking. You find the medical reason and you rule out that medical reason before you start going for easy targets that make you not have to do your job. to figure out why that woman is in pain.
Right.
And I want to tell you, a lot of this stems back all the way back in slavery. I'm sure you're very well Dr. Sims, who did experimentation in African-American slaves without any form of anesthesia to develop instruments and surgical techniques that he used on white females of the day where anesthesia was provided. And literally these women were held down either by fellow physicians or when they couldn't tolerate it by their fellow slave female colleagues, tied down while they suffered through the pain.
Right.
It is not a surprise that we're still dealing with this concept, because that concept back then was that they can tolerate the pain, that they can, you know.
They didn't die as a result of it, so that means that they can handle it.
They can handle it, exactly. And that the white women were too fragile, too frail to deal with this.
Yeah.
This is how it's been for years, and this myth has continued on and on and on. And we are such a powerful, when you look at what African Americans tolerated and how we survived through slavery, through the beatings, through the whippings, through the abuse, through the hours of labor in the field, through the hot sun, the dehydration, the attitudes that have, because we've been survivors, that doesn't mean that surviving was easy and that we are therefore, do not suffer pain or are people that are used to that kind of abuse. That was abuse.
Yeah.
And so, this day and age is unacceptable to give a different level of care to one population versus another population.
Absolutely. Absolutely.
There's no evidence for it. And unfortunately, African American women continue to suffer from health disparities in birth, health disparities in cancer care. And part of it is just this attitude like, okay, yes, we do suffer from hypertension and diabetes. Oh, well, she may die from her diabetes. She may die from her hypertension. Let's focus on that. The screening tests are not as important. And then she ends up dying for colorectal cancer or from, a cervical cancer when she could have lived because finally she got her diabetes and hypertension under control. But now she's dealing with a cancer because you decided that you needed to focus on her diabetes and hypertension, and you decided her life was going to be shortened because during this short period of time, it was out of control. And now that it's in control, you ignored the basic fundamental screening tests that can save lives. I'm a little bit passionate about that because unfortunately, I've seen it too often.
Absolutely. No, I appreciate the passion because that is the thing that needs to happen. It needs to be more physicians who don't mind being the voice of calling it what it is and being like, no, I know that this is something that has happened and it cannot continue. It cannot be something that happens in such a way that it's affecting us in this place. So when you think about that, and we know that with what we're experiencing right now with COVID is disproportionately, again, affecting Black people, people of color. How has that affected the way that you operate now in your practice with medicine?
Well, COVID has really, one of the things, of course, us as healthcare, we're dealing with it every single day. And our healthcare system is overloaded with cases. And unfortunately, being in Georgia and one of the southern states where we're not, Florida is, Florida, they're the poster child for doing things wrong.
Yep.
But I have to admit that Georgia hasn't, done the job that it needs to do. I think the physicians have. I think the healthcare systems have trying to educate the population on the importance of, PPE, wearing masks, make sure you wear it at all times, washing your hands properly, sanitizing after every, touching different objects. We've tried to do our job in educating the population. The problem is some of our population has no choice but to go to work because they work in jobs that they don't have they don't have the ability to say, I can telework from home.
Yeah.
They don't have job security. And the majority of those are Black and brown individuals
Yeah.
that are in these jobs that they actually have to have a lot of contact with people. And sometimes some of these jobs do not provide them the appropriate PPE to protect them, those masks to protect them from being exposed. And even if they have those masks, they are constantly so much being exposed to individuals, different individuals on a daily basis. It puts them at risk.
Absolutely.
Why our people are disadvantaged, have a disadvantage with this disease? It is so many social determinants within the system that are affecting why Blacks and why Black and brown people are affected. There is a health disparity in the opportunities for accessing healthcare, for be given equal services as other individuals. The other issues are we have hypertension, diabetes, a lot of the risk factors, the other medical problems that have been associated with a worse outcome because of COVID-19. We are in, jobs that don't allow us to stay home and telework and protect ourselves.
Yeah.
And it's just getting worse now because not only do we are unable to have the financial ability to protect ourselves and to get the appropriate access to care and to be able to have the means. I mean, think about it. Majority of people in Georgia who have a car, you have to have money to have a car and drive, right? Because the metro systems are terrible and they're down. A lot of the systems for traveling are down. Why? Because of COVID. Right. So our ability to get access to the healthcare, to reach the healthcare systems are challenging. We have to take Uber, we have to take Lyft. They have to pay money for these issues. They got to get, again, if there are some metro systems that they can use, they got to get exposed to other people. We just have a situation that has truly has put the African-American population at risk for dying from this disease.
Absolutely.
And because of the mistrust that the African-American community has with the healthcare system, when these vaccines come out to try to protect us from getting the disease, I have just heard so much from the community that
it is not going to be well received.
It's not going to be well received because
we don't have a good history of that. Tuskegee.
Don't. Exactly. There's just been so much experimentation from slavery on in the African-American population, in the Caribbean population, that it is going to take a lot of education, a lot of building trust within these communities so that we can get them vaccinated and protected so that they do not die and have significant morbidity from this COVID-19. And those faces, that's right. And those faces need to be brown and Black that build that trust.
Have to. That's the only way it's going to work.
The problem we have is that all these well-meaning people want to say, get all the funding, get all the money, get all the research and say, we're going to go out into these communities and we're going to, finding all these different ways that they think are going to break these barriers to get this community to come and receive the vaccination. And as part of their team from the head up, they may get some of the ground people to be brown and Black, but this needs to be leadership from the top down. Of brown and Black people working with Caucasian people together to try to get this community well educated and feel comfortable about getting this vaccine. It is not enough, and we've had too much. There's enough, Black and brown physicians and scientists to get engaged in the process of working with these communities so that the communities can trust that the person leading this endeavor to make sure that the population is safe is brown and Black.
Absolutely. Absolutely. You've covered so much, and I'm so grateful for the passion that you had. And I was going to ask you one word that affirms who you are, but I got a clue that it's passionate.
That's probably right. That is it. That's probably what my students would say, my residents would say. and my family. So you
Well,
got it.
I can speak firsthand of the passion because I've watched you work the system and be an advocate for your sister during her battle. And all I could say was like, oh my God, I'm so glad to know this dope Black woman, this dope Black doctor, because if anything ever goes sideways, I'm calling Dr. Flowers because
Yeah,
I know she's going to advocate on my behalf. And that's what we need to know. We need that reassurance. We need, like you said, people who look like us, who are not just pawns in the systems going about the work, but just people who are really on the front lines and saying, no, I'm doing this work for a very specific reason. Like, I
exactly.
need to make sure that people who look like me are protected and are put in positions to be healthy and to have longevity and to really flourish. So I'm so grateful for the woman that you are. I'm so grateful for the mother that you are, the wife, the sister that you are, the friend that you are, and the physician that you are. Thank you for being all that our community needs and more. We appreciate you.
Thank you. It's really a pleasure. It's an absolute pleasure to talk to you today. I enjoyed it. I
Thank you
definitely
so
did.
much.
And the biggest thing I would tell your viewers to that be an advocate for yourself, even if and make your doctor be an advocate for you.
Yeah.
Believe me, that's their job, and ultimately they'll appreciate it at the end, especially when they see how well your health is improving, and you come back to them and say, you know what, because I because we built this relationship together, I'm a healthier person. And
That's
I don't think any doctor would be sorry to hear that.
not a single one, not one that really stands by their oath. So
Right.
that makes me happy. And I'm so grateful that you took your time. I know your schedule is crazy busy. So I'm so grateful that you took your time to spend with us. And I know that we're going to build a partnership to be able to educate and share even more information going forward. So I look forward to that as well. Thank you, Dr. Flowers.
Absolutely. It's a pleasure.